So no one can actually see me misbehaving anyway, but or maybe you can. But I'd like to thank you all for joining remotely. For those of you that haven't met me, I'm one of the faculty members in the Otology and Neurotology division. This talk is going to be covering a lot of what I do in the lab, as well as my clinical practice, and kind of merging the two to come up with a story about why chronic suppurative otitis media should be considered really a surgical disease. The disclosures are there. There's one relevant disclosure.
Peter, use the mic, please.
I am. Do I need to go louder? I can turn up the podium. The podium mic's nearly at full. Can everyone else hear me?
That's better.
Loud and clear, Peter.
Okay. So chronic suppurative otitis media, or CSOM as I'll refer to it through the presentation. And we're all familiar with that discharging infected ear that we see there on the top left with pus coming from it. A beautiful picture drawn by Chris Graylap, really just showing that's the tip of the iceberg that you're seeing when you look into the middle ear. It really involves the whole middle ear and mastoid air cell system. We consider it a kind of a tropical disease because it has a really high prevalence around that peri-equatorial region that you can see there on the world map. But it has a predilection for those who are indigenous or low socioeconomic. But of course, my first experience with CSOM was when I was doing my residency in Perth, Australia. And kind of like the Bay Area, it looks very pretty with beautiful parks, beaches and rivers. During my residency, we would fly by light plane down there on the bottom left. It would take about 7 hours to get to these remote Aboriginal communities. We would travel with one ENT and one audiologist, and we'd be dumped in these remote communities, and we'd see 50 to 100 children in a half day. And almost all of them had some form of otitis media, and chronic suppurative otitis media has an incidence of around 45% in the Australian Indigenous community. You can see there what we used to do for the kids there. We'd recommend stage 1 would be dry mopping, where you roll up a Kleenex and you put it in the ear canal and would simply wick out the pus. Step 2 would be to flush the ear with a betadine antiseptic solution, and we get the nurses trained on how to do that. And step 3 would then be to instill some topical fluoroquinolones. We also, there was a big public health effort to put chlorinated swimming pools in a lot of the communities there. So having a school with a pool increased school attendance, as well as gave the kids a wash every day. But it does actually affect a lot of us around here. And this is actually an audiogram from one of my patients here at Stanford. And it really shows you what a typical audiogram might look like with a mixed hearing loss on the left ear. There's a conductive component, as you can imagine, with the tympanic membrane perforation and some vesicular chain issues. But also, you may not be aware that CSOM often causes permanent sensory hearing loss. So how do we manage it in the clinic? So like me, you may take a culture, and you may wait a few days for that culture to come back, or you may just get on and treat it. And you may be disappointed with that culture because it comes back as no growth. But it doesn't really matter anyway, because I'm going to treat that with topical ofloxacin otic through the ear. So cultures are only positive in 20 to 50% of cases, and so you can't really rely on the cultures to tell you whether or not there's an infection. And if you really go deeper and use PCR to detect bacteria in the middle ear with CSOM, you actually detect a whole zoo of bacteria. So, of course, the PCR doesn't really tell us whether the relevance of that bacteria. We don't know whether CSOM is a polymicrobial disease. Certainly, both on PCR and cultures, the number 1 and number 2 bacteria that are detected are Staphylococcus aureus and Pseudomonas aeruginosa. Surprisingly, there are control specimens in these studies when using PCR actually detect bacteria, and you get a difference in what bacteria detect whether or not you sample the middle ear mucosa or the middle ear effusion. So, of course, one of the things that our lab is looking at is trying to design a better diagnostic. We actually published recently on a flow cytometry method of detecting biofilms or pseudomonal biofilms in the middle ear using flow cytometry. We actually also have been doing some pilot work looking at detecting serum pseudomonal antigens in the blood and comparing that with the status of the patient's ear. And we've been 100% every time so far. We've actually used a lot of the immunological mechanisms and markers that we're finding in the middle ear and developing a machine learning algorithm to predict infection. But back to the story that we have now, and the best current solution that we have to detect bacteria is, of course, cultures. So this time we get lucky. We actually detect Pseudomonas aeruginosa in the cultures, and this time actually we detected 3 strains, and this is a real patient. Just reminding you that this is actually the minority of cases, but again, does it really matter because we're still treating it topically with ofloxacin otic. So let's dig a little bit deeper into that culture. If you're lucky, you might get a susceptibility profile, and that susceptibility profile that you can see there on the right will go through a bunch of different antibiotics and test the planktonic bacteria grown in vitro, and to test test them according to different concentrations of antibiotics. And just a reminder, when you look at that, it gives you a value according to the mean inhibitory concentration of the antibiotic and bacteria. And that is based on the serum concentrations that can be derived by that drug by the usual dosage. It is not reflective of the topical concentration of that drug. And basically, if it's around about 4 micrograms per mil or less, it's considered susceptible. Around 4 is considered intermediate, and greater than 4 is resistant. Like, we're still treating it with ofloxacin otic, or you might rub your hands together and say, look, we've got 3 susceptible strains there, can't we treat that with ofloxacin otic and be done with? So when you look at the clinical outcomes of fluoroquinolones in CSOM, there actually, surprisingly for such a big disease, there actually isn't much evidence there. We do know in the short term that we're probably likely to shift it from active to inactive. So you get either getting a pussy, angry-looking ear, you might get a stage of quiescence up there on the right. But what does inactive actually mean when you're actually following them up in the short term in these studies? And as we all know from those of us that practice in this area, there's obviously often a time of rebound, and we actually don't know how long this time of rebound takes. There certainly is a lack of long-term studies. This is a quote from one of the few studies that looked at long-term outcomes, and it failed to resolve ear discharge in about 70% of cases. Interestingly enough, there's a systematic review on fluoroquinolones in CSOM, but again, considering such a big disease, they actually only found 7 studies that met criteria, and considering the criteria only included 1-week follow-up, that's a pretty low bar. But one of their conclusions was topical antibiotics, referring to quinolones, probably results in an increase in resolution of ear discharge. Remember, that's at 1 week or to 2 weeks when compared with topical boric acid. And all the other conclusions that they looked at, they were unable to draw conclusions. So why do fluoroquinolones not work? So we've done a lot of work, and this has taken about 2 years to come up with this animal model of CSOM. So the animal model that we do involves bioluminescent bacteria. There you can see on the left, we have a variety of strains, both M. cherry, GFP, and naturally bioluminescent lab strains. Thank you to our collaborators in the Boyke lab and the Hancock lab. And we culture these, we pre-treat them with ofloxacin to increase the number of persister cells in the population. I'll explain that in a little bit more detail later in the talk. And then we inoculate these bacteria into mice. And using an in vivo imaging system, or IVIS, you can see there, if the ears are infected, they glow, and you can false colour them there in red, for example, to know that whether or not they're infected. We've actually followed these infections over time, and we found that these are stable for up to 6 months. Up the top right, we've actually quantified these with bacterial counts, and we know that luminescence actually correlates very well with bacterial counts. There's a question there. A lack of data on efficacy primarily adults, not children, from Kay. Actually, the lack of data on efficacy is from everyone, unfortunately. So the model here is looking at the persister cell inoculation of Pseudomonas in the middle ear. So we create a tympanic membrane perforation, We infect the middle ear with persister cells from Pseudomonas, and then we watch them over time. And here are some electron micrographs looking at Pseudomonas. They're highlighted in yellow. And if you use fluorescent staining, we can actually detect extracellular DNA co-localized with the Pseudomonas aeruginosa in the middle ear effusion, indicating that there's biofilms present. We've actually also correlated the grading of the mice ear with what we kind of see in the human ear. And we can actually play around with the quantities and the types of bacteria, the doses, and actually get a very different response in different strains of mice. Interestingly, we've been able to gather a lot of immunological mechanisms that are occurring in CSOM. The first responders to infection are neutrophils, and what we see in CSOM in our model is a change from these mature neutrophils, which stain for Ly6G, to immature neutrophils, which are sort of low intermediately signaling. And these neutrophils, when they encounter a Pseudomonas, one of the major mechanisms that they do is a thing called netosis, where a net or a neutrophilic extracellular trap, they kind of spew part of themselves onto the bacteria. They form this net and scoop the bacteria back into themselves for digestion. This is what mature neutrophils do, but as the infection becomes more and more overwhelming and the immature neutrophils move in, the neutrophils actually spew themselves onto the bacteria and die, and that's called the dead pathway. And you can see there the graphs over time, there is a transition from predominantly mature neutrophils to immature neutrophils, and what we are hypothesizing is that maybe Pseudomonas aeruginosa may be promoting the immature neutrophils because it actually encourages the extracellular DNA from the neutrophils to spew out, and then the Pseudomonas don't die, and they form their building blocks for their biofilms. Interestingly enough, also we have a reporter mouse for EGFR, thank you to the Coffee Lab in Vanderbilt, where we are looking at mechanisms of the TM wound healing. And we know from past research that the EGFR, the epidermal growth factor receptor, is really key here in wound healing. Interestingly enough, the neutrophils, especially the immature neutrophils, show very high signaling, increased signaling through EGFR, and maybe that is the mechanism for why the eardrum does not heal in chronic suppurative otitis media. Led by Ann Ping in our lab, we also are investigating the mechanisms of sensorineural hearing loss. So remember I showed you the audiogram from before. So structurally we're able to look into the inner ear, and using myosin 7 staining of hair cells, we're also able to look at the hair cell survival that occurs over time in our model. Looking at the graphs there, you can see that there is a predominance for basal cell hair cell death. And if you look at the bottom right of the red staining there, you can see there that the outer hair cells are wiped out on day 20, and we can increase the amount of outer hair cells that are lost by increasing the dose that we implant into the middle ear. We've also developed techniques of sampling the perilymph from the inner ear during infection. You can see that on the top right. We're able to then harvest the perilymph and examine for what potentially is causing toxicity in the inner ear. Interestingly enough, the toxicity still happens in heat-killed bacteria, so it's very unlikely to be the bacteria themselves. So back to our clinical situation of why fluoroquinolones don't work. So if you look at that mouse model, it glows red when there's an infection, and it doesn't glow red when there's no active bacteria. If you look at the bottom left, that's kind of what they look like before. Actually, after 14 days of twice-daily afloxacin treatment, very similar to how we treat the human condition. Interestingly enough, this is kind of where in the clinic we sort of rub our hands together and think that we've done a good job, pat ourselves on the back, and the patient goes home. Unfortunately, as many of us know, in the clinic situation and in our mouse model, there is rebounds, and in our mouse model this happens around 3 days later. And you can see there at day 17, the bacterial load in the middle ear recovers to levels as if you never have treated the middle ear. So this goes into the story of biofilms. So when the Pseudomonas enter the middle ear, they do so as swimming flagellated bacteria that when they go in there, they lose their flagellum, they stick to the side of the middle ear, they then form this slime layer, this extracellular matrix, they build this sort of mushrooms and these colonies, and that is what is termed a biofilm. If you look at the bottom right, it kind of explains what is going on in the biofilm. At the top, Pseudomonas, as you know, is an aerobic bacteria, and they kind of branch off and form the planktonic friends again to sort of seed other areas. But as you go to the bottom of the biofilm, it changes from an aerobic to an anaerobic condition, and at the very bottom of the cell, the bacteria become metabolically inactive, and we call these persister cells. They're not resistant because, given the chance, they repopulate with the same sensitivity, but they are actually tolerant to antibiotics because of their lack of metabolic activity. So this shows you the growth phase of the bacteria that we grow in the lab. And I think we're all getting very familiar with exponential growth phases at the moment. But you can see there, bacteria, as they grow, they have a lot of nutrients. They grow very fast. But as the nutrients in the petri dish or in the middle ear run out, they enter what's called the stationary phase, where they have very slow division. But you can see there it's not flat, it's very slow and uprising. This is when a lot of them change into the persister cell phenotype and be metabolically inactive to survive. You can see then when challenged with ofloxacin in the middle and on the left in bacterial-loaded survival, if you do treat them with ofloxacin, you can wipe out the exponential phase as you would expect because they're metabolically inactive. But they actually have very little effect on the biofilm, particularly the stationary phase component that you grow. Fluoroquinolones, the mechanism, they work by acting on the topoisomerase, which is the uncoiling enzyme that the bacteria produce to replicate. And that is only present when the bacteria are metabolically inactive. So if you get an antibiotic colony, kind of like the bottom left cartoon that you can see there, and the blues represent those that are metabolically active, if you treat them with antibiotic treatment over time, you're going to wipe out those metabolically active bacteria. And what you're left with are those that aren't replicating. And of course, if you remove the antibiotic over time, they resuscitate. So just a reminder that persister cells are tolerant, they're not resistant. And they do this because they have these repair mechanisms, just like all the other bacteria, that can activate over time. And the dormancy actually gives them more time to repair, so that the same damage that occurs in the persister cells as does in their metabolic friends, but they just have more time to recover. So one of these mechanisms is the SOS response, which involves Rep-A, which I'll refer to later in the talk, which helps repair the DNA damage directly. The other is the superoxide dismutase system, there represented in the middle of the screen, which actually acts as a free radical scavenger, which converts the O2 species to peroxide, which then can be reduced by catalase. So back to our clinical story again. When you look at the side of the bottle of ofloxacin, there's actually 3,000 micrograms per ml in that bottle. So that's way above the 0.5 micrograms per ml that this culture actually returns. So it should work, shouldn't it? Well, the reason why it doesn't is because the concentration in the middle ear would actually seem adequate. So if you look at how much of that 3,000 micrograms per ml in the bottle gets into the middle ear effusion, it's probably around 500 to 600 micrograms per ml. But there is high patient-to-patient variability. However, there is no or little drug that gets into the middle ear mucosa. And we do know that the biofilms are heavily involved in the mucosa. So that 3,000 micrograms per ml, even if all you needed was 0.5 micrograms per ml, is actually not getting to the site of the biofilm. Let's dig a little bit deeper. So remember when we looked at those cultures, we looked at MICs, which were planktonic bacteria in vitro. And remember, we're dealing with a chronic biofilm disease here. So here, we actually need to look at something called the minimum biofilm eradication concentration, or the MBEC. So instead of growing planktonic bacteria in petri dishes, we need to grow biofilms over 24 hours in petri dishes. And here is a pinwheel setup where you have increasing bacteria, so increasing antibiotic concentrations going around. And as you can see, if you graph it on the right, the MBEC of this colony of Pseudomonas is about 750, and you might remember from earlier the concentration that gets middle ear mucosa is somewhere between 0 and 600, so way under the MBEC of Pseudomonas aeruginosa. So that's just a lab strain of Pseudomonas, and this is now a shout out to my colleagues in the division who give me their middle ear samples from CSOM. But Pseudomonas and Staphylococcus aureus together are actually different in the middle ear. They actually have greater biofilm forming capacity there, as represented by the CRISPR violet absorbance study. Interestingly enough, if you look at the persistent cell populations that you culture from the middle ear, they are very high, about 16% compared to about 1% in the lab strains. So interestingly enough, if you look at that visually, when you expose them to afloxacin there, looking at Pseudomonas there in the middle panel on the left and Staphylococcus aureus on the right, the Pseudomonas that we cultured from the middle ear actually did not respond at all at 3,000 micrograms per mil. Interestingly enough, we also have a collaboration with Dr. Meir, who's a pediatric pulmonologist, and we're finding very similar results about persister cells and biofilm forming capacity in Pseudomonas cultured from cystic fibrosis. So when you're an ENT surgeon, you're faced with this mountain of pus pouring from the ear, and you have one solution, which is topical fluoroquinolones. Well, I presented a bunch of data showing you that it probably doesn't work, and it's kind of what we all know. But at least we're not doing harm, right? Well, unfortunately, we may be doing harm. So fluoroquinolones have actually been shown to induce persister cells. So you've actually made transition an acute infection into a more chronic infection in the long term. There is through that SOS response that I mentioned before, particularly involving REC-A, it induces this mechanism, particularly in gram-negative bacteria called TIS-B, and that actually causes the persister cell formation to be, the phenotype to shift towards a persistent cell formation. Interestingly enough, over a long time, and probably this is about 6 to 7 passages of antibiotics, so 6 to 7 topical treatments, the sublethal DNA damage over time leads to antibiotic resistance, both to the original antibiotic and to unrelated antibiotics. So by using topical fluoroquinolones repeatedly over time, you are encouraging antibiotic resistance both to topical fluoroquinolones and other antibiotics. So I've shown you already that CSOM causes permanent sensory hearing loss. The cultures probably aren't helpful. The efficacy of topical fluoroquinolones in CSOM is questionable. It can convert temporarily to an active disease, but how long does this last for? It doesn't eradicate persistent cells in biofilms. It doesn't reach sufficient concentrations in the middle ear or the middle ear mucosa to be effective. Unfortunately, it may do harm. It may induce the formation of persistent cells. It may promote the induction of antimicrobial resistance. So what should we be doing now? Should we give IV antibiotics together with topical antibiotics? Well, unfortunately, only about 4 micrograms per mil gets into the middle ear mucosa if you use it intravenously. Remember, our target is 750. Should we be dispersing the biofilm? So there's some really interesting devices that can be applied into the middle ear and can shape the biofilm off the middle ear mucosa. There are a lot of formulations that have been given with with topical fluoroquinolones and others to look at increasing antibiotic penetration. Interestingly enough, a lot of antibiotics actually have trouble penetrating biofilms, but topical fluoroquinolones are not one of them. If you look at the study in Staphylococcus aureus there, and you look highlighted there at the percent retardation, that is how quickly ciprofloxacin moves through the biofilm, it's 0%, which means it is not retarded through the biofilm. Looking at that a little bit differently in the Pseudomonas aeruginosa study, ciprofloxacin moved at the same speed through a biofilm as it did through a sterile control, and so it actually wasn't impeded either. So unfortunately, biofilm dispersal and increasing antibiotic penetration are not the answer for topical fluoroquinolones. Unfortunately also, we are learning that Pseudomonas actually has an intracellular life cycle. Here are some electron micrographs showing Pseudomonas actually internalizing into the middle ear epithelium and unfortunately living inside them. Also, we know that Pseudomonas can also live inside macrophages, and preliminary data from our lab actually shows that it probably lives inside neutrophils as well. So unless that treatment is getting intracellular within the epithelium and the immune cells, it is not going to clear the disease. So for those of you who are surgeons in the audience, which is most of you, you're probably rubbing your hands together because my recommendation is we should be doing more surgery for this disease. The surgery that I'm referring to, of course, is tympanoplasty with or without mastoidectomy. And the success of this tympanoplasty in this disease is probably at least 60% for wet ears or more. You might recall that I said with or without mastoidectomy. If we look at the literature, the conclusions are that there's no evidence to support doing mastoidectomy with tympanoplasty. And if you look at their conclusions, there's statements like the result in terms of hearing gain and graft uptake were statistically insignificant. The mastodectomy does not lend any additional benefit. If you dig a little bit deeper into that literature, you will see that the results and the outcomes are really about graft uptake. And also they're very short term, they're in the weeks to months. We don't know whether or not mastodectomy influences the disease over the long term. We don't even really know what the appropriate outcomes of studies should be. And this is where the surgeon must be an artist more than a scientist when deciding on doing a mastodectomy with a tympanoplasty in this disease. But I always kind of wonder why a tympanoplasty even works for this disease. Does it change the microenvironment within the middle ear? Does it simply change the oxygen tension in the middle ear because you're immediately closing the drum? Are you increasing the inflammation in the middle ear at the time because you're usually operating on the acicular chain or the tympanic membrane? I think these are areas that would be really exciting to study. And again, unfortunately, also, often think of myself as a bit of a dentist. So this is your debrider tool, your micro drill, when you go and attack the mastoid with the biofilm. So unfortunately, or fortunately if you're a surgeon, the best answer for chronic suppurative otitis media still remains surgery. So I'm very conscious of the ability of the evolution of superbugs, antimicrobial resistance, and that we actually need things that are better than surgery, unfortunately, for the patients. So I'm just going to talk you through some exciting things that are coming out of our lab that we're looking at addressing this. So one thing that we have determined is an in vitro throughput screen for CSOM treatments. We have a number of collaborators around Stanford that have promising treatments, and we're able to put them through this in vitro screen, which involves a number of Pseudomonas strains and a number of staphylococcal strains that include both lab strains and clinical isolates. One approach that has been in the literature about how to attack biofilm diseases is potentially increasing the susceptibility of the biofilm to fluoroquinolones. And there's kind of two existing theories. One is to provide a carbon source to those persistent cells, kind of like the idea if you give them food, they'll wake up and become metabolic. The other one is looking at blocking efflux pumps. So there are a number of drugs, including some gold nanoparticles, which are cationic, that are aimed at blocking those efflux pumps. And those efflux pumps, you think of them as the antibiotic enters the cell and the efflux pump spits them back out. So if you can block the efflux pump, you can maybe keep the antibiotic intracellular. Unfortunately, these two have been shown to be very unlikely to work in chronic biofilm disease in vivo. The middle ear, actually, if you sample it, is a very high sugar environment. There's a lot of food around there. This wake-up technique has actually been tried in cystic fibrosis in vivo and failed. And if you wake up the infection without the coexistence of antibiotics of the right amount, you're actually just exacerbating the infection into the active state. Unfortunately, persistent cells also do not likely have efflux pumps. Remember, I told you that they were metabolically inactive, and efflux pumps require metabolism. So this is where a lot of work has been done in collaboration with one of our research scientists, Laurent, who's a bioengineer, and he has developed these gold nanoparticles functionalized with cell-penetrating peptide, and I'll talk you through what that does. So these are ultra-small, and so being ultra-small, they behave like small molecules. They're anionic, hydrophilic, and they're functionalized with cell-penetrating peptide to allow them to passively enter the cell. The gold nanoparticle has actually been shown under acidic conditions, which is the middle ear, to catalyze the decomposition of that H2O2 to hydroxyl species, and the bacteria actually don't have an enzyme or to clear out the OH-, and actually is very toxic to them and they die. The anionic component actually competitively binds that REC-A in that SOS response that I talked about before. And so these cells, when they get damaged, they have difficulty in repairing. And as I mentioned, because they're functionalized with cell-penetrating peptide, they can get into the cell without metabolism. So if you look at, again, looking at our cultures there, looking at the MBAC of ofloxacin alone in the middle graph, it's about 750 with topical fluoroquinolones. If you use the nanoparticles alone, it's about 1600. If you combine them together, you can clean out the biofilms with very minimal dose on the right. Showing you that visually, this is in vitro Staphylococcus aureus biofilms, and this is a clinical isolate. If you flood that petri dish with 3,000 micrograms of per mil of ofloxacin, it doesn't do anything to bacterial colonies, but you can actually wipe the plate clean with combination therapy. And lastly, if you recently we were able to test these in vivo, and these in vivo mice were inoculated just as I described to you before with Pseudomonas. We then allowed them over a few weeks to build up the infection. We then treated them just like we would with a patient. There are a number of other control groups. We treated them twice daily with either ofloxacin or ofloxacin with the nanoparticles, and then we left them alone for 2 weeks, and then took the miliary fusion and cultured them there on the dishes. And we actually did have a number of samples, of these are just representative, and you can see there it kind of replicates our in vitro results where we have the colonies growing back and almost swarming the plate with ofloxacin, and only a few colonies popping up with the nanoparticles. So this is kind of a glimpse into the future, but I guess what am I doing now? So this is how I kind of manage patients with chronic suppurative otitis media. First, don't rely on your cultures for treatment decisions, but of course please keep them for our research and please send them my way. It can help you, I guess, if you're determining between bacterial and fungal, but remember, a negative culture does not mean it's not bacteria. If you really want to get a difficult patient and you're really wondering, you really need to do PCR, but then of course you have to be bacterial specific. But don't rely on the presence of middle ear effusion to determine the presence of infection. So it may be inactive, doesn't necessarily represent that ear is not infected. But of course, you have to address each patient as an individual. So when I look at patients, you have to gather whether or not you're the first or the one of many, which is the usual story of doctors looking at this patient over time, and get an idea of what their disease burden is. How long have they been treated for in the past, and what have they been treated for? Is this your one chance, or your one of two chances to get to treat them, or are they going to be lost to a rural setting, or are they going to be very diligent with follow-up? Are they really already susceptible to hearing loss, not just conductive, but are they already losing a sensory component in that ear from potential cochlear toxicity from their infection? What I've done after doing all this research is, interestingly, I've also brought this surgery much earlier into the treatment algorithm. And I do use a lot of non-antibacterials in terms of acidification, either vinegar or boric acid. If a patient does make it to surgery, I actually stop all topical antibiotics at the time that I make a decision to go towards surgery. I commence them on acidification protocols, but then I commence them on topical fluoroquinolones 1 week prior, and I really emphasize this to patients with no gap before surgery. They need to continue it all the way into surgery and hopefully converting it into inactive disease at the time of surgery. Again, don't have any firm rules here, and it's really a judgment call with each patient regarding mastoidectomy. But certainly if they have active disease at the time of surgery, I consider mastoidectomy. If they have had a very long-term burden of disease, if I'm doing revision surgery, I actually do, and I know this is against what some of my other colleagues do, I do bedding prep into the ear canal and middle ear at the time of surgery. And I also consider topical fluoroquinolones at the time of surgery in the middle ear and or mastoid after I've completed all the debridement. I actually don't give post-op systemic antibiotics for the reasons that I've shown you, that it doesn't make a difference. So now I'd like to open up for questions, but I'd also like to point out that there's a lot of information on our lab's website there. We have a lot of contributors both in the lab, a lot of visiting researchers. We have very fortunate to have a lot of collaborators all around Stanford and externally outside Stanford. So thank you very much. Can I have a virtual clap?
Yes, I just gave it to you, Peter. It's George.
Just give applause. Turn on your
Very
turn on
good.
your mute and
Very good.
Excellent
Very
job.
elegant.
Thank you. Thank you.
I've got a question for Brian. He says, I'm the best doctor ever. No, he didn't actually. He says, is there a timeline or factors that predict sentient neuron loss in the setting of CSOM? That's a good question. In the human situation, I have no idea because we see them so late. We rarely see them at the beginning of the disease. Certainly in the mice, if we pump the dose up high enough, it can happen within 3 days, and we've been able to get that model out to happen as late as 20 days.
Peter, this is Hamid.
I'm sorry, I missed that, Hamid.
In patients with purulent otitis media with effusion, you can even see early sensory hearing loss very, very early. So, and I think studies have shown over 20 some years ago that the pus in the middle ear will easily penetrate through the round window. So I think even in early phases of suppurative otitis media before perforation, I think it's prudent to drain that pus and put a tube in these ears and do the operation as soon as possible.
Yeah, that's a really good point, and I didn't cover a lot of the whole spectrum of otitis media, and I didn't also point out that Tulio Valdez is doing a lot of research in other forms of otitis media, and yes, you're very, very relevant is the fact that in acute otitis media, we do know that particularly Strep pneumoniae and other bacteria have a strong predilection for entering the middle ear. We just haven't seen that yet with either Staph or Pseudomonas in our model. So interesting enough, there's something else. But there's a long shopping list of things that could be causing toxic injury to the inner ear. From Nick Blevins, do biofilms form more on exposed bone, mastoid tuberculations or ossicles if the mucosa is lost? I have no idea. So I don't know. Sorry, Nick. I haven't looked at any human samples for biofilms. Certainly the literature couldn't answer that question either. You probably do the same that I do and probably debride as much as you can from the middle ear and mastoid and ossicles without causing injury.
Can I make a comment, Peter?
Yeah.
I think, we can learn from our rhinology fellows too as well. In rhinology, if the mucosa is removed, the biofilm is more difficult to eradicate because it adheres to bone. And I think mastoid is the same way. Mastoid to me is like an ethmoid sinus. We need to aerate the mastoid without removing the septation. So I firmly believe that if you do the middle ear work and open up the attic, either endoscopically or whichever you like, I think the mastoid will clear up after the middle ear and the attic and the antrum is opened up. And the mastoiditis that we see so frequently many times becomes a medical disease after you open up the middle ear and attic.
Yeah, that's a good point. Exactly. I kind of think of that as total biofilm load in the middle ear, and I think rhinologists probably think of it the same. If they leave one area of the sinus untreated, it kind of seeds back, and that's why you're getting these relapses over time with chronic rhinosinusitis. I think a lot of what we're learning here can probably be adapted to rhinology as well because they are affected by the same bacteria in the same chronic situations. Jennifer Aliona asks, what about the ototoxicity of vinegar and boric acid? I don't know, can you let me know? It's kind of a, choose your poison. Whether or not you leave the pus in there, which is ototoxic, or pour in some vinegar and boric acid. I don't know if they're ototoxic, Jenny. Jenny points out that she thinks animal studies have shown ototoxicity, but depends on concentration. You're very likely right, and I think animal studies have also suggested that bedding is probably potentially ototoxic as well, and I don't shy away from flushing the ears just before surgery, and we didn't shy away from flushing the ears in real life in the north of Western Australia. Another question, I don't know who IJK is, but is there any evidence of colonization of the round window membrane? We haven't looked at that yet, so we haven't looked at the niches of where the biofilm is in the middle ear. Certainly, the round window membrane is really tiny, it's trilaminar, and the outer surface actually is middle ear mucosa, so you would assume that it probably is involved with biofilm. We haven't looked at that specifically, and others haven't. But you could make that assumption that it very likely is. Being so thin, it doesn't take much for inverted commas toxins to get into the inner ear. And there's a whole bunch of things, not just the potential for bacteria, which we haven't shown, but for bacterial virulence factors, they're toxic byproducts. But more importantly, the immune system. The immune system is probably one of the most toxic things in the inner ear. You get a huge, and I didn't present any of that data, you get a very huge infiltrate, neutrophilic and macrophage infiltrate, and very likely in the inner ear as well. And they just spew out a bunch of reactive oxygen species and other things which are very toxic to hair cells. Yeah, this is from Alan Cheng. How do you think Pseudomonas causes sentient neural hearing loss? Does reducing infection prevent it? Yeah, look, that's very clinically relevant, and unfortunately I had a really solid answer for you. So the question of the mechanism is kind of the basis of an R01 submission at the moment. So I've got a couple of ideas. Certainly, in acute otitis media, strep pneumonia actually enter through the round window and other areas and get directly in there. And so the bacteria themselves are probably a likely cause. But we haven't seen that even in the acute phase. We haven't seen bacteria, and we've sectioned them all different times. And as I've shown you, we actually kind of analysed the perilymph. At least live bacteria aren't crossing in and remaining with any significant amounts in the middle ear. I think it's probably an immune mechanism. So if you look at, and you, Alan, you'd be more familiar with me on this, but looking at the other causes of sentient neural hearing loss, if you look at noise, if you look at gentamicin, aminoglycosides, if you look at cisplatin-induced toxicity, there is a common pathway that kind of ends in reactive oxygen species, which we know that the immune cells produce. We also know that in all those that I just mentioned, there is a base to apex response. There's a predilection for outer hair cells rather than inner hair cells, and we're also seeing that in our model. And kind of, at first you might think, hey, that's just because of round window exposure, but that is consistent in other models when there is no round window entry. So there is a predilection for basal, outer hair cell, high frequency hearing loss. And if you had any other ideas, Alan, I'd love to have them. For those of you who can't, can you see the room or you can only see the slides?
Peter, we can see a little chiclet of you.
Oh, okay. Well, if you zoom in, you can see my freshly shaved chin for the N95. So I haven't not had a beard in about 6 years. So that's why I'm hiding in the shadows.
You turn on the key light and we'll be able to admire your
No, I'm going to stay here, don't worry.
No, if you have a beard and you can't fit an N95, they have to give you a papper or a capper.
Yeah, I haven't tried using a microscope with that, but
Well done, Peter. Well done.
Thank you very much, Peter.
if there's no other questions, I'll let everyone go to dinner early.
Excellent talk, Peter. Thanks.
Take care, everyone.